Thanks so much for the kind introduction and also for, inviting me to a pretty historic place. I was actually just reflecting after having come down here that when you're at a place steeped in history, it's not common a lot of times for people to recognize that, and many times it's taken for granted. And one of the things that I've been struck is that preservation of the history and understanding of what it meant to the field of cardiovascular disease lives strong, not only within the faculty here, but also the staff and people who set this up. And so that's a remarkable thing. You should be really proud of it. And it's kind of inspiring for folks like me from New York, where literally people don't remember who the last division chief was. So super important and really an honor for me to be here today. I grew up in an era where I think grand rounds was one of those things where you talked about patients, you talked about data, and you tried to put them together to figure out how best to take care of your patients. And so for me, the best grand rounds were not just data, it was very patient-oriented. And what I've tried to do with this talk, hopefully I'll succeed, is to take you through my journey after fellowship, being a practicing clinician, also a researcher and teacher, of how I like to think about coronary disease. What's nice about coronary disease is it's very prevalent. And hopefully many of you don't have family members who have it, but as you get older, it's an inevitable part of life. And the way I like to think about it really draws upon data, but draws upon clinical experience that's not only experiential, but it evolves over time. And so that's how I've put this together. All my disclosures are in the CME materials. This is kind of everything. It mainly goes to Columbia and the Cardiovascular Research Foundation for trials that we conduct. So I'll start off with a case because that's how I always historically thought about grand rounds. And this is a woman that I took care of who several years ago, had risk factors, had a known ischemic cardiomyopathy with a chronic total occlusion, had near syncopal episode, and an ICD was placed. But she had worsening dyspnea on exertion, and medical therapy was escalated. And ultimately, the outside referring hospital in the state of Pennsylvania called one of our heart failure doctors and said, look, I think that she might need enrollment in a stem cell trial or for advanced heart failure therapies like LVAD or transplant. And the heart failure doctor called me as the interventionalist and said, before we do any of that, I think she might need a cath, again, to figure out what's going on with the coronary anatomy. And it struck me at the time, and it still strikes me today, that there are many patients like this out there who have heart failure, and people think about other things, but they don't necessarily think about going to the cath lab. And there's this been feeling that's developed, and I graduated in 2006, the COURAGE trial came out soon after that maybe the way to think about procedures, cath lab and otherwise, was that less is more. And there's this from Newsweek, at the time it was a different magazine than it is now, where the patient's saying no, and the entire healthcare system is predatory on the patient because they want to do procedures and make money and bill for it, et cetera. And this blows the healthcare budget and also puts the patient at risk. And that was kind of the paradigm that came out right after I finished fellowship. And you can imagine if your fellowship is done, you're excited to go out and practice, you're excited to help people, and that at the same time there are all these newspaper articles saying you're not helping anybody and you're doing unnecessary procedures. So why did that come about? Why was this paradigm espoused? And I think one of the reasons for it is we had to recognize that there were disparities in the way people were getting PCI. So this is just a map, obviously, of the United States, and you can see the different penetrance of PCI or revascularization procedures based upon where people live. Some people don't have any access to care, but other people just get a ton of procedures. New York, we get a lot of snowbirds to Florida. You can see how many procedures are being done down there. And we always tell our patients, please give me a call before someone does a cath or does some procedure on you, because I want to make sure it's legit and for the right reason. And if you recognize that there are definitely cases where this is going on, what ends up happening is societies came together and they came up with what's called appropriate use criteria for coronary revascularization. In the beginning of my fellowship, or as I started practicing, this was like a bad thing. We thought that this was not going to be good because outside societies were going to tell us how to practice medicine. But in reality, what they did by doing this is they did drive more appropriate care in the sense that at the patient level, the folks that were then coming to the cath lab typically had more severe symptoms, were on more meds, and at the hospital level, the rate of unnecessarily rated procedures went down. So I evolved. Initially, I thought this was not a good thing. In retrospect, what you had to realize, and especially for me, practicing in New York, is there was a fair amount of what I would call shamuloplasty going on. There were cases where the patient would come in, someone would stent the OM3 and tell the patient they saved their life when the patient didn't have any angina or any acute coronary syndrome. That's not likely a true assessment of the situation. And so if we eliminate those procedures and focus instead on the ones where we can really help patients, that's probably a better way to practice. And so that's how I evolved in my thinking. One of the things that was interesting is as I started to study this, the earliest efforts at appropriate use were not designed to identify overuse of procedures. They actually were designed to try to figure out, are there patients who should get revascularization who are somehow not? And if they don't, how do those patients do? And so this was the first paper on it published in JAMA back in the 90s. And they looked at patients, they looked at the charts, and they said, look, this guy's got multivessel disease and symptoms, and yet he didn't go for CABG, didn't go for any revascularization. If you didn't do that, the mortality was a lot higher than if you happened to go for a revascularization procedure. This is obviously association, not necessarily causation. But the point is that there are patients out there that don't get revascularization procedures that could benefit from them. This is another example from the Get With the Guidelines registry. These are folks who come into the hospital with a non-STEMI. They have 3 vessel disease or left main on cath. And on the right of the slide, there's certain hospitals that are medically managing that over 30% of the time. Now, perhaps some of those patients are 92 years old, maybe demented, don't want to go for a revascularization. But should that really happen 30% of the time? Or is it that they're so high risk that nobody wants to take on the case, despite the indications clearly in favor of revascularization? We had one of our fellows look at an insurance company database and look at patients who came into the hospital for the first time with heart failure. So first diagnosis of heart failure, hospitalized, obviously treated with diuretics and that kind of thing. But does anybody go and try to diagnose why the patient had heart failure by looking at the coronary arteries? Not just with a cath, but with stress testing. And it turned out within 90 days, only 27% of patients had any assessment to look for coronary disease, despite the fact that we're in the northern hemisphere and coronary disease is the most likely cause of the heart failure. So some people have said, wow, this is claims data, it's probably underreported. Well, double that number, make it 60%. That's still too few patients who are getting diagnosed with coronary disease when that could actually change their management. And it doesn't just change their management in terms of revascularization. If you actually look at the use of guideline-directed medical therapy in patients with heart failure that have a diagnosis of CAD, there's greater adherence and use of all the guideline-directed medical therapy drugs out there. So it's not just about revascularization, it's making a diagnosis. Just think about a patient comes into the hospital, they have heart failure. What's the goal target LDL for that patient? Well, it's going to be different if you diagnose coronary disease than if you don't. And so you really need to make the diagnosis irrespective of the revascularization point. So when we talk about revascularization, I think it's important to consider, we want to do it in the right patients. We don't want to do the shamiloplasty of OM3 that I talked about before, but we also don't want to miss true ischemic heart disease that patients could benefit from revascularization of, and we want to do it for the right reason. And so if we do that, I think we can optimize outcomes and costs. So the framework that I'd present to you, the way I like to think about coronary disease, is I try to answer 2 questions for my patients. The first is, what are their symptoms and quality of life, and can I improve them with medicines or revascularization? And the second is their prognosis. Is there a way to reduce their subsequent rate of adverse events like heart attacks and death and that sort of thing? What's kind of funny is that in the literature, the former is referred to as soft endpoints, and the latter is referred to as hard endpoints, even though we know that the troponins, with high sensitivity troponins right now, these are like minor infarctlets. And for many patients, their symptoms matter more to them than those infarctlets of troponin. So it's just somewhat of a way of thinking. But I'll talk about the data in terms of both of those and talk about how I like to apply the data in a patient-centric approach. So let's first start with symptoms. This is kind of an interesting way to start. This was in 2018. Again, through my practice, by this time I had started to treat a lot of patients. I felt pretty good because I thought I was doing it for the right reason. And then something like this comes out with this interesting like smiley, frowny face. Heart stents are useless for most stable patients. They're still widely used, and why are people agreeing to an expensive procedure and putting themselves at risk for a placebo effect? So where does this come from? Because I think most people now agree that we can reduce anginal symptoms with a stent procedure. Well, the way it came about is there was a trial that was done and it was published in 2017 and then subsequent multiple publications from it called the Orbita trial. And what the investigators actually asked the question of was whether if you did a PCI and if you did a fake PCI, could patients exercise differently with one versus the other? And what they showed is that after you did the real PCI, patients did exercise more than they did at baseline. It just wasn't appreciably different from the fake procedure. If this study was twice as big, this would have been statistically significant, but that doesn't really matter. What matters is that the difference between the two arms was not as great as people previously thought. So one of the first things that many people do when they look at data that they don't believe, and this is true not just within medicine but in society, is they have a pre-existing belief and they see data and they either say that matches my belief or that's completely against my belief, so that's just garbage, I'm not going to believe it. And that's not the way we should practice anything. We should basically assess something and then try to figure out what happened in the trial and then understand that within the context of what we already knew and then how we can apply it to patients. And so what's kind of interesting, though, is that the newspapers, even back then, responded this way. So unbelievable heart stents fail to ease chest pain. They don't actually help treat chest pain like the guy who's having an acute MI. So this was a problem after the study came out. I don't know if you remember this, but we had patients in the ER who were having STEMIs saying, don't put a stent in me because I heard that that doesn't help. This is another one. Thousands of heart patients get stents that they may do more harm than good. And finally, the more existential placebo effects of the heart with this like sort of interesting thing that you can think about. So what you want to really do is look into the data and try to understand this within the context of everything else. So few facets of this trial. It's a super important trial. I actually know the investigator really well. She did an amazing job with this trial as well as subsequent trials. But there's certain attributes of the trial that are important. And the first is that it enrolled patients that had single vessel disease. 30% of them did not have positive physiology or ischemia in that distribution as assessed in the cath lab. And many people said, well, this is ridiculous. How could you stent that? Well, because in clinical practice, there are a lot of people who stent lesions just by looking at them and saying it needs a stent. So that's kind of one of the things that they showed you probably shouldn't do. The other thing is that patients were on an average of 3 antianginals before they even were in the study. And they were treated for an average duration of about 8 months beforehand, because in the UK, which is where this trial was done, it takes a while to get to the cath lab. It's not like here in New York where someone's having chest pain and you can get them you can book them a case that week or the next week. There it takes a long time. And they really tried to manage the angina well. And as a result, by the time the patients were in the study, they only had angina about once a month. That's really rare. So if you take patients like that and really optimize them that way, of course it's going to be harder to show a benefit of an effective therapy versus a placebo. They also had good exercise tolerance and minimal ischemia on dobutamine stress testing. What's interesting is the investigators have studied this further because they wanted to understand this. They're all interventional cardiologists. They know that we can help people with stents, and so they want to try to figure some of this out. So one experiment that they did is they took people to the cath lab and they exercised them before opening up their physiologically significant stenosis. They then stented it and told the patient, we just opened up your stenosis, exercise again. Interestingly, the exercise increment was now a minute. In the other study, it was about 20-something seconds. So why do they do so much better now than they did in the study? Well, maybe it's because the patients knew that their artery had been opened and it was truly a significant lesion, and so they could then be exercising in a more unfettered way than if you're in a study where you don't know if you're in the placebo group or the stent group, and you might be a little bit worried to exercise more. So that's one possible explanation. In addition, within this study, in the beginning, everybody stopped due to chest pain. Almost everybody stopped due to chest pain. After they relieved the obstruction of the stenosis, virtually all of them stopped due to exhaustion, and that was associated with an increased lactate. So these investigators, on the heels of Orbita, actually showed that there was a physiologic effect of PCI. So let's take that further and let's try to look at symptoms. So they went back and reanalyzed their data from the trial, and what they showed is, remember, most patients only had angina once a month. But let's take those patients and see how many of them we could make free of angina. And when they analyzed the data that way, and they published this in Circulation, they showed that there was definitely a clear benefit of PCI compared to the placebo. So that's new data from this trial. And finally, to really sort of make it clear, they did another study, and this was published last year. They took patients off anti-anginal medications because the medicines can confound the effect of the therapy. And they then randomized patients to PCI or a sham procedure and clearly showed that PCI improved angina. So I think there should be no question that PCI improves angina. The real question is, how do we identify those patients that are going to benefit from our revascularization procedure, whether it's PCI or surgery? Within these studies, they've done another few studies, and what they've shown kind of interestingly is that if you can reproduce the patient's symptoms on the table by blowing up the balloon, and that symptom is correlated with the way they felt beforehand, then that's also predictive of their ability to free that patient from those symptoms at follow-up. So we have to be good clinicians. We really need to ask our patients a detailed history, because some people will say, I have chest pain. Some people will say they have shortness of breath, but they might have COPD. They could have a variety of other reasons. They could be, well overweight and just out of breath because of that. We have to do better. And one of the advantages of being a specialist, I think, is that those office visits that I used to hate as an internal medicine clinic resident, where I would have to do healthcare maintenance and everything else with the patient, all within the 15-minute confine, those things are much better as a specialist because we're really just focusing on cardiovascular. And so I can take the time and effort to identify exactly why patients are there or not. So just an audience question to make sure I know you've had lunch, so it gets postprandial a little bit. So the orbital results are most consistent with the following statement. Number one, there's no role for PCI for patients with stable ischemic heart disease, and it should be class 3 in the guidelines. This may sound ridiculous, but this was exactly what the editorial in The Lancet wrote. No role, it should be class 3. Number two, the symptomatic benefits of PCI over maximal medical therapy are modest for patients with single vessel stable ischemic heart disease. And number three, the shameloplasty argument, PCI should be the default therapy for all patients with angiographically severe lesions. I think you can probably already tell that I'm kind of a middle-of-the-road kind of guy, and so the answer is going to be 2. But what's also important is that the symptom improvement is going to correlate with the nature of the prior symptoms. So if somebody has kind of wishy-washy symptoms at baseline, it's not going to do them a benefit to open up their artery and expect them to be completely rid of those wishy-washy symptoms. On the other hand, if somebody tells you every time I walk upstairs, I get this discomfort in my chest, and if I stop, it goes away. Those are the types of patients in whom, honestly, you're going to have the best efficacy with some sort of revascularization procedure. What's interesting is if you look at our guidelines often say, this is a prior iteration of the guidelines, but most people in medical school are taught this, that if somebody comes in with stable disease, what we try doing first is we give them guideline-directed medical therapy. So sublingual nitro, beta blocker, calcium channel blocker, maybe ranolazine, and only if those things fail do we then consider revascularization to improve symptoms. And as a clinician, I understand why the guidelines say this. It's because they don't want to revascularize everybody. And if people are doing a lot of these bogus-ish procedures, then you want to prevent them from having to come to the lab. But if you have severe symptoms and you already have to take a lot of other medicines to prevent the disease from getting worse, do you really want to have to fail all of these therapies when we know that by revascularizing you can avoid this and actually take patients off of this? So an alternate perspective on antianginals, I think, is that we don't really talk about there are certain types of guideline-directed medical therapy that are prognostically important, things like aspirin, lipid-lowering medications, and lifestyle modification. But we don't separate out those things from antianginals, none of which alter prognosis. So every clinic fellow is like, we got to start this patient on a beta blocker. Why? There's no mortality benefit. There's no MI benefit in a patient with a normal EF. If the patient really has severe symptoms, why don't we define the anatomy and then offer the therapy that would be most aligned with the patient's interests, which are typically going to be getting rid of my severe symptoms. If the symptoms are mild, then of course it makes sense to try medical therapy, because why would you take someone with minimal symptoms and rush them to the cath lab? So that's kind of the way I like to think about it in clinic, but recognizing the fact that these other agents don't really alter prognosis. And when you talk to a patient in the office, you can't like hit them with 5 new medications, because there's data out there. If I write a prescription, actually I take that back, I'm a very good doctor, so the number is better for me. But if anybody generically writes a prescription, how often does the patient fill that prescription? Anybody know? It's 2 out of 3. Of those patients that fill the prescription, how often do they take the medicine as prescribed? Anybody know that one? It's also about 2 out of 3. So if you multiply those 2 probabilities together, you're basically 50-50 if you write a prescription in the office that the patient's actually going to take the medicine the way you describe it. So for me, I would much rather they take the medicines that matter, the aspirin, the statin, the diabetic meds, things like that, than the anti-anginals, which they actually sometimes have side effects from. So it's a different way of looking at it, but I actually think in medicine you have to recognize these basic human facts and then sort of negotiate or horse trade with your patients to really emphasize what matters to them. The reason this is important is because if you revascularize, most studies have shown, actually every study has shown, that you can get the same symptom benefit or greater symptom benefit with less anti-anginals. So you don't use as much nitrates or calcium channel blockers. And in the ischemia trial, which is a more recent trial looking at cathing patients versus medical therapy alone, if you have a high-risk stress test, they looked very carefully at symptoms and quality of life. What they did is they asked this question according to what's called the Seattle Angina Questionnaire. How often are you having angina? And so these are the numbers. If you have no angina at all, the number is 100. If you have it 3 times a week, it's 40. So in the trial, the mean number was 80, which meant that patients had angina about once a month in that trial. The reason for that is because they didn't want to take really symptomatic patients, because if you randomize them to medical therapy, they're all going to cross over and have a cath. So they took minimally symptomatic patients. But what they showed within the trial, which is really interesting, is that your improvement was directly proportional to how severe your angina was at baseline. So if you had somebody with daily angina or weekly angina, you only needed to treat 3 patients in order to render one of them angina-free by going to the cath lab. If you had no symptoms or minimal symptoms, there was no difference between the 2 groups. Why? Because if you have no symptoms, how am I going to make you feel any better by cathing you? On the other hand, if you have severe symptoms, those are the people we can benefit. And by the way, that effect was durable at both 12 months and 36 months within the trial. If you look within the trial, the conservatively managed patients, which are the ones that then came to the cath lab early, the strongest predictor was the severity of symptoms. If you had a lot of angina, you failed medical therapy and went to the cath lab. So this is like common sense. If you're seeing somebody in the clinic and they come to you and they tell you, I get a twinge of chest pain, once every other week, fine, make sure they don't have left main disease, define the anatomy, but you're going to treat that patient medically. If someone comes to you and says, every time I walk up the stairs, I have chest pain, of course you're going to cath that patient. You're not going to push beta blockers and all that other stuff on them. And so this is nicely shown within the trials as well. I will emphasize we have to be better doctors and we have to take better histories. This was a really, really interesting paper that Suzanne Arnold published, where each one of these bars is an individual clinician. And what they did is they asked the patients with the Seattle Angina Questionnaire, are you having angina, yes or no? And then they asked the doctor or the clinician taking care of the patient, is your patient having angina, yes or no? And then they correlated it. It turns out that each of these physicians had a pretty significant rate of underreporting their patient's angina. These docs over here underreported or underrecognized their angina 60% of the time. So why is that? The reason is that we're all really busy. We have to deal with Epic. We have to deal with administrators like taking us from room to room. And so we don't take the time to ask the questions that matter. So let me give you an example. So patient comes to see me. Are you having any chest discomfort? No. Do you have any shortness of breath? No. So many people would stop and move on and say, no chest pain, no shortness of breath. But what you can do as a specialist, because you literally are specializing in cardiovascular disease, is you can say, well, tell me what you like to do. They say, well, I like to hang out with my dog. Okay, so my next question is, does the dog walk you or do you walk the dog? How big's the dog? It matters, because if they're walking a big Doberman, that's a very, very different type of walk than the little rescue Shih Tzu that I have at home, where it's pretty easy to walk around. You say to them, well, so how does that go? It was actually great, but then when I walked to the end of my driveway, I started getting out of breath. That's interesting. So what do you do? I don't really do that anymore. I just sit on the couch. That's a very different history than do you have chest pain or do you have shortness of breath? And you can ask these questions in a precise way really quickly and ascertain what's going on. But you also kind of have to be savvy. Like, you can't tell patients to exercise if you don't yourself exercise. You just look disingenuous. So when I ask a patient, what do you do for exercise? I like to go for walks. I get a lot of Indian patients or South Asian patients because I'm Indian. And so I say, well, do you do the Indian auntie walk, which is this? Or do you like go for a walk like a lot of American people do, which is like, you go for a walk. And it really matters. Do you sweat when you walk? How is this going? This allows you to determine with more precision if a patient is truly having symptoms. And it might not be angina, it might be COPD or otherwise, but we have to be better doctors. So this is just an example of somebody we helped symptomatically. This is a gentleman who had low EF, PVD, prior CABG, had inferior ischemia on the stress test. Medicines were escalated to no avail, and he really came to see me because he had progressive angina, was told that not much could be done for him. And so we took him to the cath lab. This is what his right coronary artery looks like. It says CTO of the RCA. And he had a rema to this right, which was open, but there's something funny and hazy going on at the anastomosis, and it's a pretty big RCA. So I wasn't sure if that was significant or not, and back I was younger, I said maybe I'll do imaging on this and look at it. I don't think imaging is the right thing for this, intravascular, because you're gonna straighten the artery out when you wire it, and so it's gonna give you something strange. But even just during the wiring, I couldn't wire into the RCA because there was a lesion there. And so ultimately, I was able to, with a hydrophilic wire, come up, back off the CTO occlusion and down the vessel, and then I decided to treat it. So what I did is I stented the anastomosis, looks pretty good, and he went on his way. Now he's gonna come back, and I'll show you a little bit later what he came back with. But how did he feel? Because he was a real patient with a real lesion, he had ischemia in that territory, and we revascularized him. He thanks me for all of my help. It's a great feeling to be angina-free. You're a grateful patient. And this is a much nicer thing than a social media message or like a thumbs up or something like that. And by the way, that was also on less medication, because after I did this, I could stop his beta blocker. I could back off on his nitrate, because neither of those, well actually in his case, I backed off on the beta blocker a little bit, his EF was down, but the nitrate I stopped, and because neither of those really changed prognosis that much for many patients. I'm just gonna be honest, there are many patients in whom I revascularized and I stopped the beta blocker where their EF is fine, and they actually tell me they have as much benefit in terms of their symptoms from stopping the beta blocker than from the PCI itself, especially younger patients who get sluggish and have other issues. They can't work out to a good heart rate, et cetera. This is supported by the guidelines. It's class 1A to revascularize patients with refractory angina despite medical therapy and significant stenoses. Personally, I think it should be a little bit less prescriptive than that. It really ought to offer this to patients who are symptomatic and want additional options. I think this will change on the heels of Orbita 2. But it's also important to recognize we don't have to revascularize everybody. Forgetting the shamuloplasty procedures, there are people with real disease that don't necessarily need to be revascularized. This is a letter I got from a patient who came to see me with a chronic total occlusion. He was totally asymptomatic. He thanked me for taking the time to meet with him. Everybody was friendly. It was a great visit, one that was important to him and his family. So why was it important to him and his family to meet me, for me to tell him you don't need a PCI? Well, the reason is because he was deathly afraid that with his 100% occlusion, that he was gonna die or have a heart attack or something was gonna happen to him. And I talked to him, he was totally asymptomatic, he had normal ventricular function, and I said, look, there's not a lot of data that we can prevent this, and by the way, the artery's already closed, so it's not gonna close again. And he was relieved by that and sent me a note like this. So that's the part about symptoms. Be a good doctor, ascertain the history well, and treat the right patients. But what about prognosis? Can we change people's outcomes in terms of heart attacks, cardiovascular death, or otherwise with revascularization? I would dare say that most people in medical school right now are taught that for stable ischemic heart disease, there is no prognostic benefit to coronary revascularization. I think that's a true statement. Most people are being taught that. But I'd like to show you some data that shows you that maybe that's not really true. Before I show you that on revascularization, when it comes to prognosis, the most important things that we can do relate to guideline-directed medical therapy. So I'm not arguing revascularization, no revascularization, without talking about guideline-directed medical therapy. And it includes diet, weight loss, smoking cessation, aspirin, statins, blood pressure medications, and diabetes medications as well. The reason that this is important is because if you get more of these things under control, there's a much better prognosis when it comes to mortality. One of the nicest things about being an interventional cardiologist is that I can see patients just like everybody else. And I like interventions that work. So it doesn't just have to be interventions in the cath lab. As a physician, when I see people for follow-up, because I follow my patients, we spend the entire visit talking about this type of stuff. Like why you got to get exercising, why you got to get moving around, why you have to, take your diabetes medicines, all of this other stuff. The reason it's important is because we don't do very well at it. These are patients with self-reported coronary disease, and there's great, with legislation, benefits in terms of smoking cessation, et cetera, but things like physical activity, BMI control, lipid control, we're terrible at. Maybe a show of hands from all of you. How many of you have your plan for what your workout is going to be today? Nobody. Somebody worked out today already, no? Okay, well, a couple people. And other folks, do you have a plan for what your workout's going to be? So if we can't do this, how hard is it for our patients to do it? We really have to emphasize this for them and frankly for ourselves as well. We know we take care of ourselves terribly. But you need to have plans for these things, and you need to spend the office visit explaining why this is so important. Yes, we fixed the blockage, but the house is still on fire. We got to put that fire out somehow, and how are we going to do that? Now, why am I so enthusiastic about this stuff as an interventional cardiologist? It's because I like any intervention that works, not just those in the cath lab. And so part of what we do in the cath lab has to be tied to this as well. The reason for it is we're terrible at it. This is underuse of high-intensity statins in US patients with ASCVD. Look at this slide here. These are people with established ASCVD, and 50% of them are not on any statin at all. I mean, that's crazy. Now, some of it is because of Dr. Google and all the bad stuff about statins, but this is also true with any lipid-lowering therapy that's out there, and that is awful. So when we're talking about prognosis, we have to get this right first, and then we can talk about revascularization as well. So what do the colloquial newspapers say about coronary revascularization? It says that stents for stable patients prevent 0 heart attacks and extend the lives of patients a grand total of not at all. This is from The Atlantic. I actually love The Atlantic. David Epstein has written some pretty interesting books. I don't know if anybody's read The Sports Gene and stuff like that. But so I saw this and I was so upset because I've been giving this talk for a while and I like to think about these things. I actually wrote him. I emailed him and I was like, what is going on? Like, where are you getting this from? Why is this like this? It's actually far more nuanced. I actually sent him, we had a nice conversation back and forth, and I even sent him a version of this talk where I explained to him, yes, that's true for the patient with the OM3 lesion, but that's most certainly not true if you have a left main disease. How can you say that in somebody that has left main disease? So let me talk about the data. So the reason he said it is because there's a trial called Courage that randomized patients to medical therapy versus PCI versus medical therapy alone. And the overall results of the trial were negative. There was no real difference in death or myocardial infarction. For me, this was not a surprise. When I trained in fellowship, I never told somebody that that was a stable patient, that I was going to save their life or prevent heart attacks by putting in stents. In fact, I told them there's probably an upfront risk of the procedure during the PCI that we were going to try to minimize by doing it safely. But the main reason was for symptoms. But it turns out that that's for all comers disease, and it excludes patients with the most severe anatomy. If you have severe coronary artery disease, it's actually prognostically important for you. And one of the challenges of trials like the Courage or any trial that you read just the headline of is that you're basically taking the treatment effect across all the patients in the trial and homogenizing it. So if I see 20 people in the clinic, I'm saying every single one of them is going to have the same exact treatment irrespective of what their anatomy is or what I do. What we really want to do is we want to separate out patients that are going to have benefit from our procedures, offer it to them, not offer it to those that are going to have complications, and have a good discussion about those in whom we're less certain. So anatomy is really important. This is from an earlier version of the guidelines where it shows you that if you're a 55-year-old woman and you're sitting in my clinic next to another 55-year-old woman, they're not going to have the same prognosis independent of everything else. It really depends what they're there with in terms of their coronary anatomy. So if one of them has single vessel disease with a 75% lesion, they have a 93% chance of surviving to their 60th birthday. If the other one has 3 vessel disease with a 95% proximal LAD, they have a 60% chance of surviving to their 60th birthday. So the same 2 patients, they may look the same. The anatomy completely differentiates the 2 of them. This has also been shown in CT-based studies. If you do a large series of patients in Denmark that had CTAs performed, it wasn't just the plaque burden, it was also how severely obstructive the disease was that ultimately was tied to their prognosis. And in fact, if you look at other CTA studies, this was just published last year in the European Heart Journal, that there are all these things that increase the risk of adverse events, but the things that really, really increase your risk of adverse events is 3-vessel left main disease or severe stenosis seen on the CTA. So the anatomy really, really can arbitrate prognosis. The question is, why are our guidelines saying, and why are we being taught that there's no difference in terms of these outcomes? And the reason is I think in the United States, we've been over-cathing people. We cath too many people who have executive stress tests, borderline inferior ischemia, likely from the diaphragm or anterior from the breast. We bring them to the cath lab, and we don't need to bring them to the cath lab. So where is my evidence for this? This is a really interesting study from about 10 years ago in JAMA, where they looked at people in Ontario, so Canadian healthcare system, where it takes a lot more to come to the cath lab, versus New York, where you have executive physicals and people coming to the cath lab all the time. And at the very bottom of this slide, the incidence of left main or 3-vessel disease is basically double in Ontario as it is in New York. Because it takes a lot more to get you to the cath lab, they're starting to see an enriched population of more severe disease. Because here in the US, we're just randomly cathing people. It's not really that bad, but you know what I mean. Basically, you end up doing too many caths and not finding not enough disease. So if you have severe disease, though, there's clearly benefits. So this is left main disease, 2 studies, minimal number of patients, mortality benefit from surgical revascularization. This is multivessel disease, where you have a mortality benefit from surgical revascularization. The first thing people say when they see these data, they say, man, that looks like a really old slide. Look at the way it looks, because these trials are old. So of course that's true. With more medical therapy now, aspirin, statins, and things like that, our outcomes are better. But that doesn't mean that revascularizing high-risk anatomy is not important. So where is the more recent data on this? We're going to draw upon the ischemia trial. So this was a trial that aimed to enroll 8,800 patients to show that by doing a cath and diagnosing severe disease, typically, you could improve cardiovascular death and myocardial infarction compared to not doing a cath. The study actually did not enroll fully. It enrolled too slowly, so it randomized 5,179 patients and followed people for an average of 3.3 years. And interestingly, not many people know this, they did blinded CTAs up front to make sure they were not randomizing left main disease, because that would be dangerous to patients. And they found left main disease in about 8%. It's actually more like 10% because they didn't do the CTAs in people with CKD. So if you're going to take a patient with a high-risk stress test and apply the results of the ischemia trial and just medically manage them, I would beseech you to at least do a CTA to make sure they don't have a 1 in 10 chance of a left main lesion, because that would not be good for the patient. Now, most people know that the primary endpoint was negative, and this is an expanded endpoint because they didn't enroll the full sample size, where there was really no difference between the 2 arms, even though there was upfront risk with going to the cath lab, which we expect because we're doing procedures. There was a late benefit, but the net was equivalent. What people don't know, and most people don't even realize from the ischemia trial, is that the original endpoint, cardiovascular death and MI, when you look at the data from this trial, there's an upfront risk with going to the cath lab, but at 4 years, there's a statistically significant reduction in cardiovascular death or MI with the invasive arm of the trial. Most people have no idea. They just know ischemia is negative. It's actually not negative. At 4 years, there's a benefit to doing the cath and defining the anatomy, despite the upfront risk that's incurred within the trial. So you may ask, well, why are they benefiting? I thought you told me that there's no evidence that we can reduce events. Well, it turns out that if you look at studies of PCI, and this is also true with surgery, there's a reduction in spontaneous MI after the procedure with a revascularization strategy. This was published in Circulation in 2013. That's often offset by the procedural risk, but there is a late reduction in events. And within ischemia, they've assessed this and analyzed what type of MIs are prevented. It's not type 2 MI. It's actually a reduction in type 1 MI by being randomized to the invasive arm of the trial. And that doesn't matter whether you get CABG, whether you get PCI, or in the invasive arm if you get medical therapy. So you might ask the question, well, how do you, in the invasive arm of the trial, you're getting medical therapy, why is your event rate lower than just the conservative arm anyway. They're getting the same therapy. The reason is because those folks that had conservative therapy in the invasive arm didn't need a revascularization, so they were lower risk than the just generic conservatively managed patients. If you actually look within the original New England Journal publication in the supplement, there's a Bayesian analysis of the difference in event rates, cardiovascular death and MI at a year. It actually favors the conservative arm at a year because of the risk up front. But at 3 years and 5 years, almost the entire distribution is in favor of defining the anatomy and going to the cath lab. Again, not commonly known from the ischemia trial. There have been follow-on studies looking at longer-term data, and in fact, if you look at extended follow-up from the trial, there's a statistically significant reduction in cardiovascular death in the ischemia trial, but that's predominantly observed in patients with multivessel disease. Totally makes sense. You're never going to save someone's life with the PDA or the OM or even the distal LAD. If you have multivessel disease, though, and you define the anatomy, that is prognostically important. Now, it's offset by an increase in non-cardiovascular mortality that is not well understood. It might be fluke, it might be real, it might be some of the antiplatelet therapy that we use, but nonetheless, there's a reduction in cardiovascular death. And the authors have gone further, and this was published last year in your intervention, that if you on CTA had 3-vessel disease and you were randomized within the invasive arm of the trial, not the non-cath arm, in the invasive arm, there is a benefit in terms of cardiovascular death and MI, irrespective of whatever subsequent treatment you receive. So the second question I'll ask all of you before heading to the conclusion part of the talk is with regards to the prognostic benefit of revascularization. Number one, there are no patients for which coronary revascularization has been shown to have a prognostic benefit over medical therapy. This is the medical school teaching. Number two, the prognostic benefits of revascularization are manifest in higher risk patients, but they take time to offset the procedural risk. And number three, I'm going to save your life by any revascularization I do, irrespective of your risk. Once again, it's in the middle, but it's important that there actually is a benefit. Now, I'm not telling you you need to revascularize every patient. In fact, there are many patients I see who are asymptomatic, and I say, look, you need medical therapy. You all have EPIC, we have EPIC. I have a phrase, the AJK, my initials, ischemia. I type .AJK ischemia, and this is what comes out. And that is we had an extensive discussion on the basis of this trial. I don't see any prognostic benefit to going to the cath lab and figuring this out. I would therefore recommend medical therapy for the time being. It would change if something changed with the patient. We discussed the risks and benefits of this approach. I do have in the disclaimer, I did mention we can never predict the future. It's certainly possible that an adverse event could occur, but the important statement is I'm not confident that I could prevent that event from occurring with an invasive approach, especially based upon prior randomized data. So I don't cath everybody. I try to make a rational decision, especially if they have a CTA or something up front, and then figure out what to do. And this is entirely supported in the guidelines. While many people, think that the ischemia trial was a negative trial, there is actually a class 2A recommendation on the basis of the ischemia trial that says if you have stable disease and multivessel coronary artery disease, it's appropriate for either CABG or PCI. Revascularization is reasonable to lower the risk of cardiovascular events such as spontaneous MI, unplanned revascularizations, or cardiac death. This needs to find its way back into the medical school curriculum. So to sort of conclude, and where I've taken this in terms of my approach to cardiovascular care in the cath lab, is we really didn't want to focus on the shamuloplasties anymore. We wanted to look at patients that could benefit from the revascularization procedures we did. And so we wanted to focus on the highest risk patients, those that have the most symptoms or the most severe anatomy. And we wrote this sort of white paper on the evolution within our field, not focusing on the shamuloplasties, but focusing on other things. First and foremost, I want to emphasize you got to do the medical therapy right. So we looked at our own cath lab, and for 400 of these patients that had PCI for CTO, left main, or calcific coronary disease with atherectomy, it was sad but true that we recognized that only 43% of them had their LDL less than 70. That's horrible. So what did we do? We actually said that when you draw pre-cath labs, along with your PT and your INR and your CBC and your creatinine, we're going to draw a lipid panel. And we've written about this and basically said we should state what should be obvious, and that is that when we see the anatomy in the cath lab or do an intervention, we tell the patient we've fixed what we needed to fix, but the house is on fire, and you therefore need to do this right now with your lipid-lowering therapy so as to achieve the best outcomes. So medical therapy is super important. But beyond medical therapy, you also need to learn specialized skills to be able to treat these high-risk patients. And so I'm not going to go through this, but there are a lot of skills you need to learn. So back to my guy, he came back. He had recurrent angina, and now you see he's got a tight lesion within the stent on that bend of the rema. So it becomes challenging. What do you do with this? Because it's on a bend, like he's a drug-coated balloon, I could use a lot of things. But what I actually wanted to do is just open the native coronary at that time. For many people, this is not approachable. You can't do these cases, but with dual injections, you can actually figure out where the RCA should be. And with specialized techniques, an anchoring balloon in the conus, ADR, so you come down subintimally in the vessel, we re-enter in that stented area, you can basically do the case and open up the native coronary artery. I still follow him years later, and he's great. He's doing way, way better. His angina got better, and he still remains off the antianginals. The problem is not everybody can do these cases. In the US, if you look at the average interventionalist, they do less than 1 PCI a week. That's the problem. You need specialized centers to be able to do this. What we do at Columbia is, because we're on a salary type of model, is we have specific operators who do high-risk cases, and we double scrub with other operators so that when you come to the Columbia Cath Lab, you're getting essentially the same level of care irrespective of who your primary operator is. The reason we think that's important is there's data like this from the busiest cath lab in the world. This is Fuwai Hospital in China, where left main disease, based upon your operator volume, high volume operators have a lower cardiac mortality than those that are low volume. And the high volume ones are probably doing more complex cases. So for simple cases, it probably doesn't matter. For the really complex stuff, this type of stuff does matter. There's also institutional stuff that matters. So this is a very interesting study of CABG versus PCI. Each of these balloons is an individual site. At this site in the trial, the rate of adverse events with CABG was 40%, but with PCI, it was minimal 10%. This site, it was 50% adverse events with PCI, 0% with CABG. If you're a patient, you don't know which of these bubbles you're going to, but if you're the physician at one of the bubbles, at this place, you really don't want to have bypass surgery, and at this place, you really don't want to have PCI. So we need to be better about conveying these things to ourselves and understanding our strengths and limitations. In fact, that's in the guidelines, where the guidelines talk about spending time to engage with the patient, allow for a second opinion, discuss the specific risks and benefits with procedural and outcomes on the operator level, so that we're giving the patient what they best deserve as a patient, not what I feel comfortable providing because I'm limited in terms of what I do. So to conclude, I'll just point out the way I like to think about medicine is, through these personal examples informed by data. And this was an interesting one. You all know who this is. I'm down in Houston, of course. So he had a PCI done. And at the time this was done, this is really American medicine at its worst. He's the poster child for the inappropriate use of stenting. Now, unfortunately, I don't think either of these folks reviewed the chart, saw the patient, or anything like that. They're just like opining off the cuff. And I think one of my residents once told me when I was an intern, don't ever opine on a case definitively unless you've actually seen the patient. Nonetheless, this was said this way. And so what was interesting is he was asked at a subsequent meeting, what did you think of people saying all this stuff about you? Now, you remember, if you remember him, he basically has a lot of one-liners, and they're often self-deprecating, they're often inadvertent, and they're always, it made him look funny at times. But in this case, the best one-liner ever. It wasn't their LAD. They can say whatever the heck they want, but it wasn't their LAD. So he had a subtotally occluded LAD. He's an avid cyclist, and he wants to bike in the woods and do all this stuff. It's his decision as to whether he wants to do it or not. And so ultimately, it has to be patient-centered. So to conclude, what did I attempt to convey today? Well, first, coronary disease and the clinical syndromes associated with it really should be treated with therapies aimed at symptom relief and prognostic benefit. The location of the disease, the type and severity of the symptoms, and the patient risk will most often dictate the benefits of revascularization, informed by a healthy dose of common sense. Don't do procedures because you're going to bill more for them. Do to the patient what you would want for one of your family members, and really try to be honest. Are the symptoms real? What does the anatomy look like? Interventional cardiology can be as cerebral as it's technical. We always talk about the in-lab stuff, but it's not just that. It's interventions that work that we are most happy about, not just those occurring in the cath lab. And I really think it feels great to think when practicing clinical medicine. We don't often have enough time to do it, but when we can actually think and then use that data to apply it to our patients thoughtfully, communicating that judgment to our patients, That's our fundamental responsibility as physicians. It's actually a privilege to practice under those environments, and it's what's fulfilled me in my career, and hopefully you can get some inspiration out of it. So thanks so much for listening.